9
Yes.
a.m. on a Wednesday. This is Bits and Bytes. MyHin's Bits and Bytes, a monthly workshop where stakeholders can connect directly with MyHin solutions designers and managers. So this is sort of a complementary forum to The Download. The Download is also a monthly workshop where we talk about the interaction between health and tech. The Download is more like larger topics, right? Interoperability or patient access or how to improve clinical workflows, sort of like the whys of health information exchange. And Bits and Bytes is meant to dig in a little bit deeper to MyHin solutions. We are not here to sell you on these today, folks. We really would love to know. Well, I'll get there. So you know what? Let's start it out. Bits and Bytes. Rachel, next slide, please. Thanks. My name is Joanne Jarvie. I am the Senior Director of Outreach and Market Communications at MyHin. I'm like the Yenta of MyHin. I'm up in everyone's business. I'm in everybody's sort of, sticking my neck into everybody's department, asking what's going on, what we need to be telling our customers and clients and stakeholders, really just connecting people, connecting projects, finding opportunities. Please write me, call me, let's talk often. I am here really to connect and really to engage. And I want you to know that my door is always open. I will connect you back to the people who can give you the real answers. I don't know enough. I know enough to be dangerous, but I don't really know enough. But I will use the breadth and depth of our full organization to get you what you need. Next slide, please. Rachel Kelly is helping us out today. She helps me out every day. Thank you, Rachel. She'll be looking at the chat, making sure that we are getting to everybody's questions. For those of you who don't know, MyHin is the nonprofit neutral organization that builds the statewide shared digital infrastructure for health information sharing. We aim to connect disparate sectors to securely and legally share information to help people get better, to live longer, to live deeper. We are an unbiased data trustee. We do not provide health services. We do not create our own health data. We are not competing in the healthcare marketplace. We are really just here to connect digitally, legally, securely, with privacy foremost. And I think that what's most important also to remember is that what we build and what we do is all to support human beings. Data is not necessarily communication. I still believe in communication. I still believe in making sure that we have the full picture and telling the story. Technology is the tool, and the tool is there to support humans. And does this mean that MyHin is an access point? James, is MyHin considered an access point?
I think I would define a lot of what we do as providing access, or sort of aligning with considering MyHin as an access point. Historically, it's been an access point information, and we've been pushing that information out to different folks who want to receive it. More and more, that will be shifting towards being able to query for information through MyHin as an access point. But yeah, I think that's a good way to describe MyHin.
An access point. Should I add that? Is your name Mick or Nick? M? With an M? Roger.
Yes, it's Mick with an M.
Cool. Did we answer your question?
Pardon me?
Did we answer your question?
Yes. I would have some technical questions, but I don't want to dominate this meeting.
You don't want to dominate? Well, maybe we'll need you. Mick, I'm going to come back to you.
Okay.
All right. I think Does anybody have a question about MyHin? Does everybody understand this sort of slide? Can I move on? I'm going to move on. Thank you. So really, we are here. These are the questions that I want to ask you guys. You know, we're gonna bits and bytes. We're gonna show you some of our solutions that matched up with what we talked about in the download, which was engaging patients, making sure that we are improving clinical workflows, and what MyHin solutions support that. But I would really love to hear from you all. You know, are you working with these solutions? Which features are most valuable? What's missing? You know, what problem are you trying to solve by using these solutions? How would you rate your ease of use? What about the value? How can we improve? So I hope you're not here to be sold on anything, because we are here for your feedback. And I don't want to, that's the purpose, really. We want to see how you guys engage with our solutions, or how you would. Next slide, please. Here's our agenda. This is me. I think we're almost finished with number 1. Thank God. We're going to move on to an offering called CareConvene. Chris Bailey hosted the download this past week, and he's going to talk a little bit more about the product that supports the health innovations that he was talking about. And if you guys did not go to the download, please let us know. We'll send you the recording and the slides, and those are always available on our website as soon as we get those recordings back. Then we're going to have James Nolan, MyHin Senior Product Marketing Manager and Product Architect. He's been with MyHin for a long time. He knows his stuff, and he's going to be talking about message delivery, which is not disconnected from what Chris will be talking about. And you'll see how they overlap here in a minute. And then I'm going to ask you guys more questions, and then we're going to go on with our day. I hope that sounds okay with everyone. Does anybody want to add anything to the agenda? Great, let's keep going. Well, who's next? Oh, CareConvene. All right, Chris Bailey. I think
you have my
you
slides.
have your slides. You're up.
I do. You want me to share mine, Joanne?
Yeah, can you share?
I can. Yep.
Great. Rachel, we'll come back for message delivery.
Sounds great.
Okay. Let me know if you can see my screen. So I just want to say, take Joanne up on her offer to answer questions or catalyze conversations within MyHin. She's done that very well so far and connected a lot of dots, you know, even internally between stakeholders. So definitely take her up on that. So today's
Chris.
Yeah, you bet. No, I appreciate it. So, you know, today's conversation, it has a theme about communication. Just a quick background. My role is a director of consumer health strategy. And again, I'm not necessarily here to sell you anything, but really challenge people's thinking. And so whether you're interested in this product or you have another product, I just want to challenge you to offer the very best to patients and consumers. But CareConvene is a comprehensive digital health platform that connects patients and care teams on demand everywhere, removing barriers to effective engagement, communication, and care. Our products help provider care teams, and that's important. It's providers and their care teams build strong collaborative patient partnerships by balancing accessibility, convenience, quality, and affordability. So that really is CareConvene's mission, what they're trying to do, and why MyHin is so interested in supporting that. Real quick, here is the CareConvene platform. It has several pieces to it that help support engagement and activation. There is the quintessential telehealth modality that does do patient-initiated virtual visits, waiting room type stuff, practice-initiated visits, via apps, via mobile web. So you can text a visit to somebody, you can start it via an app, you can report symptoms, etc. Then there's a care coordination component That is ADT delivery with specialized filtering and alerting. That's both web and app-based. That's a tool for the entire care team. It also supports continuity of care. The third and the newest, probably any of you who are using CareConvene really haven't even seen this yet. It was just released. It's the Outreach Campaign product, and what that does is that engages and activates patients to communicate with modern tools, the same tools they're used to using for every other advanced industry segment or sector. And so that's surveys, screenings delivered via email, via text, and it's proven to be very easy and very effective. And then there's a consolidated consumer health information, and basically what that is within the CareConvene app, that gives patients the ability to consolidate their health information into one platform. We've seen over the years the health vaults and things like that from Microsoft and Google and things like that, trying to pull data into one place. They pull it into what I would consider a dead end. And that dead end is, great, I can put information in here, but what can I do with it? And the CareConvene, my take on that is, let's pull that information in together so that information informs, alerts, but also is used to support clinicians who are caring for that patient in a virtual engagement encounter. And so that works in tandem with MyHin's interop station. James is the product leader on that. He could speak more to that, but that's MyHin's product for converting payer claims into FHIR resources. So third-party apps like CareConvene can pull that information down and segment it into a personal health record that a patient could experience. And then something that's coming earlier this year is a collaboration tool that'll support community-based organizations and clinician-to-clinician communication. So that is the platform at large. But this is one of my favorite quotes, and it's from a independent physician in Grand Rapids. Communication done right is at the root of most every positive experience in medicine. Conversely, communication done wrong is at the root of most every negative experience in medicine. And if you think back to your experiences, they're generally good or bad based on the communication. Either that lab result that came back that you completely didn't understand and were worried about at 9 o'clock at night, but you couldn't get a hold of your doctor, or the discharge instructions that you get are incomplete and vague, or you have a very difficult time or perceived difficult time communicating with your primary care practice. That's all poor communication, and that is the reason we're doing what we're doing. We're doing it to improve communication. So in the next couple slides, I'll be brief. I'll just walk you through some of the experience of what we're doing and what we built to support that. Here I'm showing you the app experience. So this is a patient CareConvene download app. Patient sets up an account. They connect to their practice. Their practice might assign them assessments, like one to manage congestive heart failure or diabetes, or to report social determinants. Those types of things can be opened and submitted to the provider care team at any time. If there are negative sentiment responses in that, it'll signal the care team so that they get a hard text saying, hey, you have a patient that's reported some symptoms. That is the frictionless path to communicating issues. Additionally, what I'm showing here on the next two is CareConvene is a synchronous, asynchronous application, meaning patient submits for a visit, they're waiting for the care team to pick up. Anyone in the care team can pick it up. It's not just a provider's job. It's just very similar to how a patient would walk into an office. They're going to come to the front desk. They're going to be asked for their identification, their insurance. The next, they're going to maybe answer a few questions. Then the MA is going to room them. The RN is going to come in and ask them questions. And then the provider comes in. In the same way, the CareConvene visit is not the video. It's the whole interaction. It's the chat. It's the assessment. It's the video interaction, potentially by multiple care team members. And so that's where CareConvene is really differentiated. It's building an experience that everyone in the practice can use, and any practice can use depending on their resource model and their licensure. You just stop me if you have any questions. So this is a view of how you would send out a visit to a patient who doesn't have the app downloaded, who might not be using the app-based experience, but you need to get them a quick visit, similar to a DoxyMe or a Blue Jeans or something like that. You need a quick text link or an email link, and it opens up and it creates that chat and video experience. Moving on, so we get into sort of the next product here, which is our care campaigns. Care campaigns are meant to be sent out one by one. You can bulk upload a list of, say, 25,000 patients with colorectal screening gaps in care and be able to send them these assessments. And this is just an example, right? You know, you could bundle 4 assessments together. Maybe you want to give them an SDOH, a congestive heart failure, a colonoscopy screening questionnaire, and maybe an HCAP survey for patient satisfaction. You could bundle all those together instead of sending separate ones out. The patient can then fill that information out. All that information comes back into the platform for the care team to review those results. Again, you can send out 1 or 2 at a time, and I'll show you some other things here, but the care campaigns, the telehealth, and the ADT are all tools that can be used separately. You may have a DoxyMe, but you might not have a good way to really filter in on ADTs, build those specialized filters for your practice, and receive those in app alerting. That's what CareConvene can help you with. Additionally, you know, you might not have a tool to send out assessments and engage.
Thank you for choosing Tim Hortons. How can I help you today? Yeah, hi. Can I get a omelet bite of the spinach and egg white?
That sounds good.
Sounds amazing.
Doesn't it? I know. Add a matcha latte in for me. So all of these things can be used together or standalone. The power is when you can pull them together. So for example, we use the ADT system. We deliver ADTs. We filter based on what that care team wants to look at. Some care managers may want to look at one provider's ADTs. Another may want to look at a special program. Someone may want to look at admissions from competing hospitals. Some may want to be looking at discharge to SNFs. So depending on what you're trying to do and the date range you want to look at, it provides all that filtering. So when we think about ADTs, the whole purpose of a discharge ADT is to reduce the likeliness of a readmission. If that is the case, the next question is, how do we do that effectively? And so not only do we deliver the CCD in there, but we have a way in which we can send a discharge assessment out to that patient. ADT comes in, someone's looking at it within 24 hours. They try making a phone call, they don't get a hold of them. So what they do is they click the discharge outreach button. It sends that patient a text and an email assessment asking them questions about new meds. It asks them questions about follow-up visits. And it counts as that 48-hour interactive conversation. That interactive digital conversation will then put that patient into an option to schedule a 7-day virtual visit, which means you can basically close loop that that transition of care. And so that's the value when you take the ADTs, the assessments, and the telehealth, and you merge them together to complete a modern patient experience. Move on to the next one here. Here's an example of that outreach. They get a text. It's branded to the practice. It's branded to the payer, whether a patient, a practice, or payer wants to do this. Asks them some questions. These aren't the most up-to-date images, but they suffice. And then once they answer it, it kicks them right into a scheduling option. So you can put scheduling blocks out there so that whether you're following up on a colorectal screening initiative or you're following up on a discharge ADT, you can now have that scheduled visit. Within 15 minutes of that future visit, the patient gets a text. That text tells the patient to join the virtual visit. The care team then jumps in, asks questions, rooms them. Provider or care manager, whoever's facilitating that interaction, can do the visit and close it out. Documentation's included. And so that is the sort of the ADT and the outreach. Another product that we have in here, it does not, so it does not, it's a great question. CareConvene is not an EMR and is not a registry. It supports both EMRs and registries. Thank you, Jenny. EMRs have always been built with mostly the provider in mind. I think we probably all agree. Their patient portals are getting better, but I would surmise they have not really built consumer solutions at all. And obviously nor has registries. They all three fit a purpose. CareConvene is supposed to be that piece of technology that helps the practice build that digital bond, creates that partnership between the patient, because all of your patients are used to world-class digital experiences, whether they're, picking up something from Lowe's or they're going to, even a fast food store. You can buy it through the drive-thru. You can go in, you get it curbside pickup, or you can get it delivered by another app. Those are modern digital experiences. So, great question, Jenny. Keep them coming. Remote patient monitoring. CareConvene does integrate with RPM vendors, such as Garmin, Withings, Fitbit. There's another called Arrow Health that has cellular-based technology. Dexcom, continuous glucose monitor. There's a project out there. And the concept of remote patient monitoring is, the purpose of it is to collect information to tell a story. The purpose is also, to the right here, to show that at some point, those vital signs, the heart rate exceeded a control limit. And so providers don't want every piece of data. They just want to know when their patients go above or below a certain control limit. And that's what we do. We take that information, each data point, and deliver it so that the provider care team can get that alert and be able to respond to it in real time. Either a follow-up, a questionnaire, or a virtual visit. But that in itself is not enough information. And I think this is where a lot of programs who are trying to collect RPM data are missing some of the context with it. So yeah, that heart rate's high. Is the patient running? Are they dehydrated? When I run for over a couple hours, I get dehydrated, and my average heart rate is a lot higher. So the context is important, and that's why there are subjective remote patient monitoring assessments. So if we can tie the objective data to the subjective feeling, we can build not only data but context to it. And that's again where what we're trying to do is build context in there. Amaz Fit, not yet, but we can look at it, Dan. Is it Amaz or Omaz? Amaz. We'll look into it. Thanks for the suggestion. I'm almost at the end here, James, so I'll turn it over to you in a sec. There are other things in here, patient care goals. How do you create goals? How do you manage them? There's tools like that. And then I think this is the last slide, is the third-party consumer payer integration. So as I was telling you, one of those products allows a patient to go in and using their credentials to say Blue Cross, State of Michigan, some other endpoint Kaiser. I think CareConvene is connected to 14 different payers across the country. It allows you to pull all that information down into your personal health record. At some point, the idea here, right, is this data you see on the right, I look at that, and as a patient, I'm not sure how helpful that is. It's there. It's there for my provider when they want to do a clinical interaction, because I can share that back to them. But where this becomes really valuable is if you look at one of these screenshots, you'll see the home button on the bottom, and you'll see the journal button. That journal is going to tell a longitudinal health story for the patient. As this matures, as the consumer access APIs mature in the industry, and we get more data, that journal function will take all of that information and tell a story about the patient. And based on their age, gender, medications, diagnoses, etc., could potentially work much like your dashboard in your car. You're running out of gas, your tire needs air, it's time to get an oil change. Those are the things that patients need. They need that interactive and upfront, and not waiting for someone from a practice to reach out and tell them. So that's what we're doing. That's where we're headed. That's the end. Happy to answer questions.
Thanks, Chris. So Rachel, I think that, thanks a lot, Chris. I think that before well, I don't know. I mean, maybe we should go to those questions and have questions now, or we could do the questions at the end after James talks a little bit more about, ADTs and all of the message delivery that MyHIN supports. Let's go back to our slides, Rachel. Does anybody have any pressing questions right now? I don't want you to lose them.
This is Dan. Just a quick question. How much of the ADT messages that are flowing through my gateway can be directed towards CareConvene and become a part of that wonderful product?
Yeah, thanks for asking. It's a good question. So the CareConvene and My Gateway are two strategies, right? They're both important in terms of using the ADTs. The My Gateway is going to be a very rich experience when you're trying to look at a lot of more longitudinal data connecting to things. That's our strategy to accessing as much information as possible. When you're delivering tools to the clinician, bedside, roomside, and you need to follow up quickly and use some of these consumer outreach components, that's really where CareConvene fits in. So they're products we recommend using together, especially because My Gateway allows you to upload your acres. But as soon as you create an acres file for your organization, all you have to do, I say all in air quotes, is basically create a second file with CareConvene in the file name, and you can have data going both to My Gateway and to CareConvene. And there's a number of ways in which, as a PO, you could have an organizational OID, but each of your practices could use their practice OID, and so each specific practice would only see ADTs related to their practice OID.
So in other words, you're using more of the raw data of the ADT. So I know that a lot of people are sending extra data in ADT messages that don't show up in My Gateway, but you would be able to view it in CareConvene.
Well, I don't know what that data is. I think the goal of both is to make sure that data is visible. So CareConvene does parse ADTs. It has an ADT engine that parses the information out of the ADT segments, HL7 segments. So in that case, as long as there's knowledge that there's data there, then yes, they could be pulled out and shared in the space. It also allows you to, one thing it does too is allows you to create and add some additional specialized filters. So maybe the information in the HL7 message isn't enough to create specialized filters, meaning maybe you need to filter more than just admission, discharge, inpatient, emergency. Maybe you need to create some special tags where you search on employers or locations or special programs, or maybe you're trying to build a specialized filter based on payers and products. It allows you to do that as well.
Awesome. Thanks, Chris. I'll contact you later about a few more questions. I have to jump to another call. So thanks for
Dan, we'll miss you.
Okay.
Thanks, Dan.
I know. I'm going to miss you guys too.
Come back.
See you later.
All right.
All right. Bye-bye.
Look, now we have James Nolan, who's going to really complement what Chris has put out there by talking a little bit about, next slide, please, Rachel, by talking a little bit more in depth about how MyHIN supports message delivery. Chris talked a lot about, he talked about ADTs, he talked about CCDAs. We want to talk a little bit more about about lab rad trans, diagnostic imaging, and sort of all of these services and how MyHIN works to support the data exchange necessary for this type of work. James, this is the only slide I have, James. You got to dig in. You got to tell us a little bit about, message delivery as a whole. And then I think what we'll do is we'll have people ask about what is most, interesting to them or questions that they have. We will make it more of a discussion.
Sure. Yeah. So I think Chris provided a pretty good real world example about how some of this information that's sort of delivered through the MyHIN infrastructure can be leveraged to support specific actions that are sort of necessary and can be taken by providers and are important for providers to take either to meet different quality-based standards that they're trying to target, or to just coordinate care more effectively and efficiently. So message delivery as a whole is sort of the bucket that we put all of the different use cases and services that sort of deliver or revolve around delivering pushing messages from one source, a sending facility, out through MyHIN's network to receiving organizations. That includes it's a pretty broad bucket that includes sort of 3 categories that are sort of broken down even further than that. So there's a lot of things that we put in that message delivery bucket. The key things that most folks are familiar with are the ADT or admit discharge transfer notifications use case. And then we also have the exchange CCDA use case. So ADTs are important for, assume most folks are familiar with ADTs, but they're important for sort of providing real-time notifications across the network to different folks that are part of a patient's care team about the status of a patient. So they have some clinical information in them, but they're really useful for identifying sort of when one of your patients or when a patient has been sort of admitted or discharged or moved from one facility to another. So keeping track of where that patient is and understanding when it's time to sort of maybe intervene with that patient, as Chris mentioned, and showed sort of some of that capability in the CareConvene application. And then the CCDAs are really the bulk of the focus there originated and sort of started around the medication reconciliation use case, where we're looking to provide or utilize the CCDA and push CCDAs across the network to sort of allow different members of the care team to reconcile what the patient's most current medication list was as they were being sort of discharged from a hospital or from a recent stay at a facility. That's sort of continued to expand, and now that we've sort of expanded that out to different ambulatory facilities, we've pushed that into the more of the care summary space, where not just looking at the medications specifically, but also looking at more information that's available about that particular visit, so that when not only are you notified through the ADT notifications about the status of the patient, but then you can also dive deeper into what happened during that visit and identify anything that might be important to follow up on or to note, either for the patient's next visit, the next time you see the patient. And then we have the third category that's really, again, another subcategory is what we call results delivery, and that includes all of the lab results, radiology results, transcription results, any of the diagnostic imaging, the transcribed documents, lab rad, pass, and trans, if sort of all get grouped in together as this sort of sub bucket, and that's where we're delivering all of the sort of individual results that are generated through one of those visits. So typically, you'd see a lot of that consolidated in a discharge summary, but sometimes it's more important to get the individual messages, the individual results delivered directly into your system. the bulk of this exchange, so Chris showed from a CareConvene perspective what it looks like to be delivered into that application, and Dan sort of mentioned My Gateway as in conversation we're talking. This information is available through that, especially from the My Gateway side, specifically the ADT and CCDA information. But it's also the way that it's mostly delivered today to receiving organizations is directly into their directly to their EHR or into an application that's ready to receive that data. So there's a number of different ways that we can provide that information to organizations, from direct secure messages that we deliver to a specified direct secure messaging inbox, or directly over like a VPN connection right into the EMR, or through an API. We also have recently put together a solution where we can aggregate that data into a data lake on our side and provide access to that data lake to an organization. So there's a whole bunch of ways we can make that data available, but the goal is to get it to the right place in the right way as efficiently as possible. So anytime we're looking at sort of getting this information or making information available to the care team, one of the things that we definitely is leveraged and will always be leveraged is sort of the active care relationship service. That's what we use to capture the relationship information. It's what we're using to identify which providers, care team members, or organizations want to receive information about that patient. And then we use the health directory to capture more detailed information about like the specific use cases you want to participate in. A provider may care about ADT notifications and want to receive lab results, but not necessarily need to receive the CCDA, or they might want to receive everything, and it might depending on which patients they're talking about in their population, or different populations that they might be connected to. They might want to receive different sets of data at different places or through different mechanisms, and that's all tracked and managed through ACRES and the health directory. So really, the maybe the last thing I'll mention before we sort of get into the bulk of the discussion I hope we'll have is we're also currently measuring conformance on ADT, CCDA, and ADTs and CCDAs, and that has really been instrumental in sort of helping improve the data quality for both of those message types, making sure that we are getting consistent and complete messages from the sending facility so that we can deliver those effectively to the receiving facilities. But yeah, so to Joanne's earlier point, we're those are the ways that we're delivering that information. That's the type of information that we're making available. What we're mostly interested in is how that's working for the folks that are on the phone today, and what questions do folks have, or what ways would you like to see that information sort of made available that maybe we aren't making available today.
Yeah, what are our next questions here? Now we're going to turn the camera, Rachel, to the next slide. But we're going to turn the camera on the participants. You know, who here, I'd love to know who here is currently working with MyHIN on these solutions, on these services, these products. How are they working for you? What's missing? What more could we be doing? What could we be doing better? Does anybody can we start some dynamic discussion around how you work with all of this data?
Hi, Joanne. This is Tina McConnell from Family Healthcare. How are you today?
Good. How are you? Thanks for being with us, Tina.
Absolutely. We spoke a month or so ago about some struggles that we are having with some of the new services that we're spinning up, and MyHIN is involved in those. And I just wanted to let you know that we're still struggling, but we have a new person involved from MyHin, who I think is determined to get it sorted out for us. And just wanted to let James know that I did know a couple of questions, and I'll probably engage with you offline outside of this.
Tina, your account manager is Megan, right?
Yep.
Great. Yeah. So Megan and James have been working together for, I don't know, like a decade. So they share lots of history and lots of knowledge. So you are in the right hands.
We are. Yep. I just wanted to share that we're still working on it.
Great.
Tina, it's Megan. I want to let you know too that I have some further information with Chelsea this morning, so I'm going to connect with her.
Okay.
And additionally, myself and Joanne are actually going to meet with Munson and all of the practices that fall under Northern Michigan Care Partners in March, so we can really provide a overview of MyHin and the different services and address some of those questions that I've seen come through, you know, as it relates to acres as well.
That will be awesome. Thank you.
Superb. Chris, I don't know if you saw, Mick. Mick's got some interesting work going. And I don't want you
Good
to
morning.
Hi.
Okay, I'll just give the basics. Most of you can see my chat. So,
Mick, where are you from?
I am a director of the Southeast Michigan Health Information Exchange, and I'm a banker in Ann Arbor at the University Bank.
Oh, no way. Okay, tell me more.
Okay, this has been going on for 10 years. And finally, because of the virus, it has become real. So many, as Chris has noted to you, many physical transactions that are occurring right now are about to become digital. So as a result, the Federal Reserve banks have built a platform that can process faster payments in 6 minutes. This is very valuable in the healthcare space because we all know the payment process is bloated and it's a mess, and it has to be made more efficient so that people get their money faster. So in order to provide what we want to, which is called e-invoicing and e-payment solutions that interoperate, the Federal Reserve has formed a working group called the Business Process Council, and I'm on it. What we've done is we've created a totally new, this is totally new and revolutionary for the United States, a template based off of the ISO standards, and some of you are probably familiar with ISO 222. It's been deployed all over the world except in the United States. So this new template we worked out within our standards body, x9.org, with our European, Asian, and Latin American financial institutions. And we have a template that contains the ISO 222 messages, which tie into what Chris was talking about. But for those who are aware of EDI payments, because it's there, the EDI solutions are part of the template that we've created. So, okay, we've created this template. So now we have two sub-work groups, one for what the architecture and infrastructure looks like, and that means what the delivery system looks like, which ties into what Chris said. And we have a data quality sub-work group because we all know that there are issues with data quality. So my chair, the Fed allowed us to create, because healthcare is special. Healthcare is diverse, it's fragmented, it's 20% of our GDP and 28% of all the data that's flowing through the global data ecosystems which are being built is healthcare data. And for national security reasons and for regulatory reasons, all of these transactions, including the patient data, has to be protected. And we can't go it alone and do it in isolation. We have to do it in a national collaborative effort. And that's essentially what we're talking about. And because payment is so crucial, the Federal Reserve, Treasury, and my larger brethren are leading the effort to do outreach to groups such as MyHin to ask you if you'd like to join the healthcare working group and bring your expertise, because we need to understand how your platforms actually work so that we can adapt our platforms in order to process an invoice or remittance and a payment.
Okay, wait, Mick, before you go on any further, I have a great idea. I have like 7 great ideas. And I think that like maybe, you know, I hope that you'll follow up. You can absolutely follow up with Chris directly. But I'm thinking that you may want to also connect with our Interoperability Institute. We have synthetic we have opportunities to exchange sort of synthetic data in new environments, and you guys could use MELD. You could use these environments to test out what you're talking about. But I mean,
are you talking about the gravity effort?
No.
Okay.
The gravity effort is to create standards around social determinant of health data.
Okay, go ahead. So I would like to reach out to that group, of course, because that's my role. Part of my role is to talk to groups like MyHin, and yes, I am talking to OHC, HHS, NIH, all of those, CDC, all of those people, eHealth Exchange.
Great. It sounds like you need to keep connecting, but I'm your person. Let's do this one-on-one.
Okay, but the point here is that we have to do this together. We can't do it separately. The reason is, and my focus tends to be security. We can't design the security to protect the data and these transactions on our own. We have to agree upon a set of methods, profiles, and standards. And the reason why I asked Chris the question, and then I'll shut up, is because the other day, Patty Ritter from the Federal Reserve of Minneapolis was talking about protecting access points and how we do that and how they are critical to sharing data across platforms, blah, 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 blah.
Are you familiar with the CARIN Alliance, Mick?
The which alliance?
CARIN, CARIN.
No.
Are you familiar with the Sequoia Project?
Yes, I'm a member of the Sequoia Project, and Dee Dee Davis, who I know very well, is aware of what I'm telling to you. And one of the areas where she wants to go is payment off of the eHealth Exchange.
This is fascinating. Probably a little too in the weeds for bits and bytes. And if I had a bagel, I would have like had 7 bagels by now. But I absolutely, I'm gonna come back to you on this. I'm not gonna let this drop, but I don't think that right now we're gonna go any further.
Okay.
Any further into it.
Done my job. Thank you very much. We'll talk.
Thank you, Mick. Tell me, whoever else is out there, how you are using, or if you are using ADTs and lab results, how you are engaging around, you know, diagnostic imaging or radiology lab information, how you are engaging your patients and how you are using technology in your workflows. Does anybody have any good ideas, any questions, any challenges? Is there anything more you'd like to learn in the space of 8 minutes? Okay, so Rachel, let's keep moving.
I'm sorry. Hi. Can you hear me?
I can. Who are you?
Hi. Hi, my name is Karen Adams, and I'm with Ascension Medical Group, and I work with onboarding new providers. And
Yes.
I think the ADT is what we're looking at to help with those quality measures that we're trying to take one EMR and put it to another, and they're not talking very well. So like if you take it from Epic and move it into Cerner or whatever. Athena, we have a Athena in Southeast Michigan, but I have two main questions. One, what is the way that we can gain access to the MyHen space for this, the thing that you presented today to help with outreach and closing those gaps in care? And the second question is there a streamlined approach when trying to move a provider or even a department into another EMR that MyHen is familiar with working with, so that we can start the provider off with the quality measures that are needed to meet the gaps in care that he has in his old EMR. But getting into the new EMR is kind of the struggle that we're going through right now. So those are my two questions.
Thank you for your questions. Megan, you are our Ascension gal, right? We have Chris Manthe, who is who works deeply with MyHen, who we'll be meeting with on Thursday. And we know that you guys have different EMRs. Megan, do you have suggestions right now for how we can help here?
Karen, it's Megan. I don't know if I've had the pleasure of talking to you yet, so it's nice to hear your voice on these calls. And as Joanne stated, I've been working pretty closely with Chris Manthe and Katie Goulet prior to her departure from Ascension. So I've been slightly exposed to Ascension Medical Group, but probably not in the aspect that I would like to be. So I actually want to talk to you further about what you kind of brought up today, because I think it's going to take some brainstorming to figure out how we can best help you. And so I'm not sure if you have my email address. I'll drop it in the chat. And if
I'm
you
on
have
the phone.
Joanne's. Oh, okay.
Oh,
do you have Joanne's email address by chance?
I
I have yours.
Okay.
Do you have mine?
Yeah.
Okay, Joanne,
Okay,
if you can send that to me, we can connect offline and we can talk through this some more.
Yes, absolutely.
Awesome.
Yeah. Look, Megan's your gal, and you're super lucky.
Oh, good.
I mean,
well,
all of our account executives are amazing. We have them on the line too, but you happen to be, you got Megan. So I will make the connection. I have everybody's email address that is with us today, so I can write you whenever I want.
Joanne,
awesome.
I missed the name from Ascension.
Oh, me?
Yes.
I'm Karen Adams.
Hey, Karen. CareConvene works very closely with the Physician Alliance. If you know, so the folks over there, Sharon Kradich is a great person to reach out to hear about what they're doing and how they're using the tools. So if you have any interest,
yeah, I know her. I have a monthly meeting with her, so I will ask her too.
Absolutely. I'm here as
Hilton
well.
Webb's here. We will get back to you, Karen. I have, like I said, I will connect you back up. Who else? Come out of the woodwork. Tell us what we can do. Be with us. / we have 3 more minutes. I'm not even on the camera. Now I'm on camera. Look, our next download is Wednesday, February 16th, followed by Bits and Bytes, February 23rd. I can't believe it's almost February. If no one has anything else to add, any other questions, if you didn't feel comfortable sharing today, you can 100% always reach out to me or to any one of our account executives. And I just want to thank you for being here. I want to thank you for engaging and spending your time. And we'll catch you on the flip side. Thanks a lot.
Joanne and Chris.
And James.
Thanks everybody for your
Thanks,
time.
James.
Yes, and James.
Poor James. All right, Rachel, let's make sure to get the chat. I'm actually just pulling up the chat. I know we have a lot to do with Nick.
Yep, I'm
Make sure to get back
just
to Karen Adams.
getting that.
Of course, we have Tina, Megan, you know. Very well done, folks. Thanks a lot. Bye.
Have a good day. Thanks.